as in the United States. So roughly in a year, we see around 21,000 cases of CLL, and if you look at the deaths, there are around 3,000 to 4,000 deaths every year in the United States because of CLL. For a diagnosis of CLL, what we need is an absolute B lymphocyte count of more than 5,000, sustained for at least 3 months, and then also, I think we may need to mute whoever is in the background. Also important to ensure that the clonality of circulating B cells is confirmed by flow cytometry or demonstrating that there is light chain restriction. So with that, let's move on to our case, and I'll hand it over to Paul to go over the cases.
Thanks, Sid. So let's get started with the first case. The patient is a 76-year-old woman with distant history of stage 1 breast cancer treated with neoadjuvant chemotherapy, surgery, adjuvant chemotherapy, and radiation hormonal blockade. She's had no evidence of disease for the last decade and a half. Her past medical history includes COPD and benign pulmonary nodules, as well as bladder incontinence, chronic fatigue, and episodic diaphoresis. She has had a cardiac catheterization, which showed mild CAD, and also has GERD and a Schatzky ring. She's referred to medical oncology and hematology for clonal B-cell lymphocytosis barely meeting the aforementioned criteria for chronic lymphocytic leukemia that Sid just mentioned. So on exam, she has bilateral small axillary adenopathy with a soft systolic ejection murmur and no hepatosplenomegaly. Imaging included her recent yearly mammogram, which showed only the evidence of her prior breast treatment, but also new bilateral axillary adenopathy with an impression of bilateral adenopathy may represent lymphoma or leukemia or other systemic reactive process, ultrasound or biopsy performed if needed. Go to the laboratory data, we see a increased white blood cell count with lymphocyte predominance at 62%, normal hematocrit and platelet count. Her peripheral morphology demonstrates absolute lymphocytosis with small mature purine lymphocytes. Her chemistries and LDH were within normal limits. Flow cytometry shows that abnormal B cell population measuring just over 5 × 10⁹ cells per liter with an immunophenotype positive for CD19, CD5 DIM, CD20, CD22 DIM as well, CD25 DIM, and CD23 with monocytic light chain expression. FISH panel was performed and showed a 11q deletion as well as 13q deletion. And the recommendation at this point was no intervention and return to clinic in 4 to 6 months with a focus on reassurance and education.
So the question for, I think, I would like to bring in our panel at this point. The question at this point is, do you agree with the recommendation to just observe at this point? And do you ever use the molecular or the cytogenetic abnormalities to decide when to treat somebody? So especially in this case, I mean, would you be concerned about 11q deletion? And if this was a 17p deletion, would you consider treatment sooner? So let me start by bringing in Dr. Aboulafia first and see, Dr. Aboulafia, what are your thoughts?
When I saw her, I thought she would do reasonably well. I was a bit concerned about that 11q deletion, and am not typically, or I don't often see the two FISH cytogenetic abnormalities at the same time, but was concerned about the 11q and the fact that she did have adenopathy to begin with. As a tiny point, this 13q and approximately 50% of nuclei, and I read something about if it's less than 65, that offers a good prognosis, but if it's over 65, it may offer a lesser good prognosis. So my focus at that time was on reassurance and trying to get her educated and up to speed that she may end up needing treatment in the foreseeable future.
Dr. Nabhan, what are your thoughts at this point? Would you ever use cytogenetic abnormalities to decide on treatment sooner or later?
You know, that's an excellent question because obviously currently there is really no role for the prognostic abnormalities to determine timing of therapy. So you could take the contrarian argument and say, well, why am I really checking those if I'm not going to use them in terms of determining therapy? You are determining the indication of treatment based on whether the patient is symptomatic from the disease or whether the disease is progressing rapidly enough. So you're really using the IWCLL criteria to determine the timing of initiating therapy. So the information that you provided certainly allows you as a physician to better understand the prognosis of the patient, but really today deciding on treatment is irrelevant of this information. This information will be important in determining the type of treatment that you want to start when treatment is indicated. But it really does not tell you that you need to start treatment earlier than sooner. There are a couple of studies that I am aware of that are ongoing nationally and internationally trying to answer the question of immediate versus delayed therapy based on the prognostic abnormalities. I'll have to tell you, I'm not really certain that these trials are going to honestly answer the question just by virtue of the fact that the disease has such a long natural history and patients do so well. So by the time, frankly, you have a control arm or the actual treatment arm, you know, the treatment has changed. So it will be interesting to see. But what I would tell your listeners and your audience is that this information is important to have a smarter conversation with the patient about prognosis, about what I'm going to do, but it really should not persuade you to start treatment earlier than what's indicated.
Perfect. Thank you, Dr. Nabhan. Dr. Chaudhry, do you have any additional comments on this?
No, I think I agree with what's been said so far. I think this is more of a prognostic sort of tool than anything else right now. I'd observe, just like the recommendations are now. You know, one could. I suspect that's your next question, but I'll wait for you to ask the next question.
Okay. So Paul, moving forward, I'll hand it back to you.
Thank you. So over the next 2 years, her hematocrit did decline. Iron studies showed an inflammatory block. This was hypoproliferative based on reticulocytes, and we've seen MCV 94, RDW 13, and notably Coombs negative. Mirroring this is an increase in her white blood cell count and absolute lymphocyte count.
So the question now again is, you know, now that we have rapidly increasing WBC and anemia, would you recheck a FISH panel, or do you feel comfortable with the original cytogenetic abnormalities that we had noted? And so I'll start with you, Dr. Chaudhry. Would you recheck a FISH panel again prior to starting the treatment?
Well, for somebody who's been untreated and been observed, I usually don't recheck a FISH panel. One can make an argument if the duration has been pretty long before any treatment, first line or subsequent line, that one should check a current FISH panel. In a situation like this, I'd probably, you know, err on the side of taking what we have, but one could make the other argument as well. So I'd actually go with what we have.
Dr. Nabhan or Dr. Aboulafia, any other comments?
I'll just chime in. So, you know, I don't know if I would have done it. I agree with, you know, the idea that she probably did not need the FISH panel with the first cycle of evaluation, because I think we could have provided her with reasonable information just on what we knew already. But given that instance and knowing that additional mutations can take place, I typically will, if I'm about to initiate therapy, I certainly would get a FISH panel at that point. In this case, it showed something interesting, and that was that the 13q deletion was suddenly not 50%, but 81%, and the 11q and 90%. But I think you could also take Arvind's point and say it doesn't change treatment recommendations at all.
So back to the panel, then what treatments would you propose at this
point?
So
Sid, may I comment on this? Because I think, and Paul, I mean, it may not change the treatment because we saw similar chromosomal abnormalities, but we may have seen something additional, clonal evolution, or maybe the karyotype has changed. So I mean, I tend to believe that it's, you know, at the time when you really think that the patient needs therapy, rechecking a FISH panel is very reasonable. I mean, because it was 5 years, I believe, right? It was. And you really, yeah, you really don't know always what happened during the, I mean, I think as long as the patient is observation, I don't routinely recommend rechecking FISH panels because you're not doing anything with that. But if you check it at diagnosis and then now something has changed, obviously, something has changed that made you decide to start therapy, something clinically has changed, you don't know on the molecular level or the genomic level if something has changed. So I tend to recommend checking the FISH panel at 2 points. At any time you decide to start a new treatment, or at any time you see the disease course has changed clinically, that makes you wonder if something new has happened. But I see the other point.
Gotcha. Yeah, that's a very good perspective to have. So from a treatment perspective, then, what would you propose at this point? She's 78. She has increasing WBC. So I'll start with you, Dr. Nabhan.
Yeah, I mean, I think, you know, it's interesting. Anytime you ask these questions, 5 years ago would be different than maybe 3 years ago, different than today. But so treatment is indicated. I think that there has been enough studies out there to suggest that novel agents, like the ibrutinib, the BTKI inhibitors, are effective regardless of frankly, the abnormality. I mean, initially, as you recall, when we started using it, we used it in 17p, but then we realized the activity is really regardless. And there have been several randomized studies in older and younger patients. I believe we'll get to that later to support their activities. I think that my preference here would be ibrutinib to start therapy. I don't see any contraindication for that treatment, and that would be my choice.
Gotcha. Dr. Aboulafia or Dr. Chaudhry, any comments or disagreements on the treatment choice?
Sid, could you go back to the slide that shows the white blood count? No, I agree with what Chadi just said totally. This patient, you know, this was late 2019 when she actually began treatment, and the choices may not have been as many as there are suddenly and now, but ibrutinib was the one with the most experience and the one that it felt most comfortable with. And as was mentioned, there was no contraindications to treating with ibrutinib. And the only point I wanted to make from this slide was that it took a full year for her lymphocytosis to finally resolve, or a little bit more than a year. And as you can see, her white count actually started to increase for a short period before it gradually declined. But my choice was ibrutinib for this patient.
Okay. So with that, let's look into our case number 2, and then we will go into the literature review after that.
So this is also in the frontline setting. This is a younger patient, though, with I'd say, less common, different initial presentation, where the disease is a bit more aggressive to start. So this 48-year-old man with no significant past medical history presents with B symptoms and lymphadenopathy, splenomegaly on exam, and a leukocytosis up to 38.5 on the CBC with a similar immunophenotype on flow cytometry that we saw in the first case. Despite no significant cytopenias here, the bone marrow biopsy did show substantial CLL involvement. And so in the bottom here, we just see this is modified Rye staging, where this patient would fall in the intermediate risk group by virtue of that lymphocytosis and enlarged spleen with adenopathy. So I make a point to bring up the RYE stage. This is, of course, the Molecular Tumor Board, but to recall that the RYE and Binet staging, which were developed in the 70s and 80s, these two staging systems still remain today. They rely solely on physical exam and your standard CBC without imaging studies for those findings of adenopathy and hepatosplenomegaly. They're inexpensive and can be readily and consistently applied across patients, so not to lose sight of the importance of these. Then considering molecular biomarkers, this is coming from NCCN guidelines. This table is really providing information or variables that can have prognostic information for survival and time to progression in patients who receive treatment. So this patient clearly we're thinking about treatment already. When we think about IGHV mutations, that's a particularly important one. Recall these are generated through somatic hypermutation. This is a physiologic process to generate immunoglobulin diversity during the normal B-cell maturation. So B cells with mutated IGHV have undergone this process, whereas those with unmutated IGHV have not. The flow cytometry correlates to this, which are somewhat less established, would be the CD38 and ZAP70. And then as far as other sequencing, it includes TP53, which we'll talk more about in just a moment, and then FISH, which we've discussed a bit already at this point, and then karyotyping or conventional karyotyping of stimulated CLL cells. The definition of complex karyotype varies a bit from paper to paper, but typically at least 3 unrelated chromosome abnormalities in more than one cell on karyotype.
Paul, could you also highlight what are the abnormalities then that would be associated with favorable and those with unfavorable?
Yeah, absolutely. There's kind of a busy slide. So mutated IGHV, so a CLL clone that has gone through that process is favorable, whereas unmutated is unfavorable. And then you see the CD38 and ZAP70 that fall beneath each of those categories, which would be correlated or associated with mutated or unmutated, rather, IGHV. TP53 mutation, along with, which often goes with deletion 17p, are unfavorable. The other FISH carrier finding, which is in the unfavorable group, which was present in our first case, was deletion 11q. In the intermediate or neutral group would be having no findings on your FISH probes, or quote-unquote normal, or trisomy 12, and then deletion 13q as the sole abnormality being considered favorable. So in this patient, the IGHV mutation testing did show unmutated IGHV, and FISH showed a number of abnormalities, including deletion 6q, which is fairly rare finding, deletion 13q, and then most notably the del 17p, and clipped from the pivotal paper from Professor Donor with the establishment of a hierarchical model of chromosome abnormalities. Deletion 17p is kind of the one that carries the day here. The worst of these findings is what you go with. And just one other point to make, as you see the FISH panel here, and there's a translocation 1114, either by FISH probe or by cyclin D1 expression, it's important to exclude mantle cell lymphoma when you're looking at cases of CLL, which can have a similar immunophenotype, but of course varied treatment and courses. And then lastly, this patient did have TP53 sequencing as well, which was positive. The point to make here is that TP53 aberrations can include deletion 17p and or TP53 mutation, and so it's estimated that up to 1/3 of patients who have a TP53 aberration, meaning either one of those, may carry only the mutation in the gene and thus would not be detected by FISH, which is the argument for doing both FISH and either Sanger sequencing or some high throughput sequencing of TP53 prior to initiation of a treatment where that's going to potentially, would dictate your treatment decision.
So I think at this point, we saw that this patient obviously has TP53 17p deletion, but we also talked about some of the molecular abnormalities. And now I would like to bring in our panel, and we will obviously review some of the literature behind this. But just talking about this from an approach perspective, I mean, how do you sort of make sense of all of these molecular abnormalities to decide on treatment? That's question one. And then the question two, I think Paul brought up a good point, is a lot of places, especially in developing countries, do not have the ability to do sequencing. So what do you think about the importance of doing a FISH and a Sanger sequencing or a MGS for TP53? So let's just start with Dr. Chaudhry. Let me bring in Dr. Chaudhry and see what his thoughts are.
Well, yeah, so my thoughts for this case would be that obviously the TP53 mutation kind of is the driver of prognosis in this situation. So that's where I think the most important molecular abnormality I would consider. Now, the others, obviously, for the 13q, as the previous slide also suggested, that if it's the only abnormality, then it's favorable, but when it's associated with others, then it's not. So I'd say, he's got sort of unfavorable characteristics of the TP53 mutation. So I'd use that as the prognostic and the treatment marker for this case. Now, as far as the thoughts about the gene sequencing, of course, the more deeper down we can actually sort of tease out the mutation, the better information we'll have. So one can always make a justification for more information. But it's also important to understand that then we are talking sort of lower numbers, and if there's countries where this is not available, we'll have to use the information that we have. So those are my thoughts.
Dr. Aboulafia.
Oh, I thought that was really well said, and I agree with all the points. We don't typically do gene sequencing studies here at Virginia Mason, but we'll do the molecular studies through FISH, and we'll do the P53, recognizing that we may check or may find an additional 25% of patients who have the P53 deletion. And in terms of treatment, this would definitely catch my eye in terms of what his situation is and where he's moving.
Dr. Nabhan?
Yeah, I mean, I think there are two parts of your question that are important. I mean, number one, obviously, in a resource-constrained environment, what do you do? And that's a very tough question to answer, to be honest, because you just have to utilize the resources available to make these decisions. Many years ago, I used to think that everybody who has 17p will have a TP53 mutation, so really you can get that through the FISH by default. But as Paul actually mentioned, and I'm sure you're going to show later on, not all patients, you could see TP53 mutation, even in patients who don't have the 17p deletion. Not a lot, but there's enough out there. So in a resource-constrained environment, utilize the information that you have and you proceed. I think the good news, or the silver lining in that, is that the frontline therapy in these patients you can make an argument that it's probably going to be the same nowadays, regardless of whether the P53 is mutated or not, based on the randomized studies. So I think that's maybe the silver lining. So, and the other thing that I was going to say is I haven't, and I'm curious what the other panelists and listeners have been doing, but I haven't been utilizing the IGHV mutation status in decision making, except if I'm considering chemotherapy, obviously. So you want to do it, but it's also not available to everyone. It's a tough question to answer, because if you can't get the mutational status of the IGHV, then you're going to miss on the proportion of patients that might still benefit from systemic chemoimmunotherapy. So I'm curious really from listeners and others what they do about this, because we sometimes are spoiled in the U.S., to be honest.
Yeah, that's a very good point. Dr. Aboulafia or Dr. Chaudhry, any comments on the IGHV mutation status and use of chemoimmunotherapy?
You know, I usually order it more or less reflexively now that it's part of NCCN guidelines, and I know that the insurance carriers will cover it. Previous to that, it wasn't always covered, and it's very expensive. You know, in truth, as kind of Chaudhry mentions, I'm not sure I would use FCR, you know, not in this context, but in maybe a different context, but with mutated form in a young patient, I'd still probably move toward novel agents, and so it's becoming less important to me.
And I don't have anything to add to that, and I think the utility of the IGHV mutation for determining therapies sort of now become very, very narrow, and just like that David said, the decision making for a young fit first-line CLL with are we going to use FCR or not? But I think that would be the only place where I'd consider it. But again, that's not even a deciding factor anymore. And I think we're all using kind of novel agents. 2 years ago, it had been a different discussion. But now I'd say it's having diminished utility.
Perfect. So with that, let's review the literature on frontline treatment of CLL and how the field has evolved over the last several years. So Paul, I'll hand it back to you.
Thank you. Yeah, excellent discussion. This patient, being 48 years old, unfortunately ended up having a number of adverse and high-risk molecular features where the conversation or consideration for a time-limited or immunotherapy approach appeared less of an option here, and we'll see why. So this is looking at CLL-8 study, which compared fludarabine and cyclophosphamide to fludarabine, cyclophosphamide, and rituximab, and shown to improve survival. And then on the right, we see the prognostic impact of deletion 17p in both groups in PFS and OS. The circle is kind of highlighting the darker line being FCR and the dashed line being FC, but PFS on the top and OS on the bottom. And then, sorry, on the left, really that you see that top curve, which has really a nice plateau, which we'll see again in the next couple of slides, but in the FCR group, the IGHV mutated patients doing quite well. So CLL-10 compared FCR to BR, and you see that this benefit, the best outcomes amongst those patients with IGHV mutated disease in both the patients treated with FCR and BR. This is a PFS slide. And then this interesting report with extensive follow-up, nearly 13 years of follow-up. This was a phase 2 study evaluating FCR at MD Anderson, showed not only the IGHV mutated patients did the best, but that also this MRD negativity post-treatment was highly predictive of long-term PFS. And you see that top plateau and the years stretching out along the x-axis, which is really remarkable, and I think leads to that allure of chemoimmunotherapy that has persisted despite a lot of these advances with novel agents. And MRD is something we'll revisit as well. So here, moving then to those novel agents, this was the pivotal RESONATE-2 trial. You see the much superior PFS improvements with the ibrutinib treatment compared to chlorambucil, and that's irrespective of IGHV mutation status. Then moving to the large cooperative group trials from the past, reported within the last couple of years. This was the ECOG 1912 showing progression-free and overall survival benefit with ibrutinib plus rituximab versus that gold standard chemoimmunotherapy of FCR in the younger, fit, untreated CLL patients. Of note, given what we've already talked about today and seen in the prior slides, patients with deletion 17p were excluded here. There was patients with TP53 mutation, which snuck in, but it made up a small amount, only around 5 or 6%. so the small boxes here are simply showing the PFS for all patients, the middle slide showing that most dramatic difference among the patients with IGHV unmutated status, and then the intention to treat overall survival showing a superiority with ibrutinib. And then the Alliance trial was similar setup, but looking at ibrutinib with or without rituximab versus bendamustine rituximab, or BR, in untreated CLL in older patients. And this did have a small amount of del17P in it and mutated TP53, but you see that regardless of ibrutinib with or without rituximab, it was superior in PFS to BR. And then most recently, the CLL14 trial, this is from the original publication. They actually just published a 3-year efficacy update in Lancet Oncology last week, but continued to show this progression-free survival benefit with venetoclax plus obinutuzumab versus chlorambucil and obinutuzumab in untreated patients with comorbidities. And so that was the key here. And some other important points from this is that it's a time-limited option, and in the bottom slides here, I give the TP53 and IGHV status. These are kind of hard to see. I think these are from the supplement, but the top 2 lines there are on the left side are the venetoclax obinutuzumab treated arms, and you see in that solid line, the second one down, yep, that that's the TP53 aberration, either deletion or mutation, patients treated with venetoclax and obinutuzumab, and most of those events are coming after 12 months or after that treatment duration. And so this has led to some discussion or debate on whether this arbitrarily defined treatment duration is appropriate, or whether patients with high-risk features such as TP53 may benefit from continued or longer treatment. And this is something, as well as MRD use, which will hopefully be addressed in the ongoing cooperative group trials. And this next slide, I think, is just to, can't really do the cross-trial comparisons, but I think it's just worth noting. This is just a phase 2 small trial of patients with CLL, and all of them had TP53 alterations treated with frontline ibrutinib at NIH. And you see that 2-year PFS in this population of 85% versus, which was, I think maybe 10% or so higher than the similar in the fixed duration venetoclax obinutuzumab in the CLL14. So I think, again, ongoing trials to determine really long-term outcomes with venetoclax-based treatment and not. This is just a backdrop for, I think, the panel discussion, given what we've already had, and to kind of revisit some of the points that we'll have. There's going to be differences in approaches, provider to provider, and there's a lot of patient to patient discussion to take into account as well. But I think just a backdrop to have in reference as we have this next discussion.
So I think excellent presentation, Paul. So I think looking at the data now, I think there are a few questions that comes up with what Paul presented. First is, is there a subset of patients where you would still consider chemoimmunotherapy? Second question that comes up is, what about MRD? How do you sort of fit that into clinical practice, or is that not ready for clinical practice yet? And third question that comes up is mostly in TP53 mutation carriers, is time-limited treatment approach is still appropriate, and do you go with venetoclax or do you go more with ibrutinib? So starting with first question, let's start with the chemoimmunotherapy question. So going back to the panel, do you think chemoimmunotherapy is still sort of your first line for any subset of patients? And I will start with Dr. Aboulafia.
Oh, well, thanks, Ed. I hate to be dogmatic here, because I could easily imagine a 35-year-old coming in with these features and a mutated form. And thinking about FCR, I haven't used FCR in truth in several years, and my experience with it was not great. A lot of those patients did develop protracted cytopenias, particularly neutropenia, that would last for sometimes in the years. And I think there's some long-term concerns about FCR and the risk of MDS down the line. And so I think with all the newer therapies that are coming out and options that even go further than this with CAR T cells, I'm still leaning toward novel agents and not, but I think the appeal of 6 months of chemotherapy is not to be dismissed either. And FCR is not a cheap treatment choice, but neither are the others. So I'll leave it kind of up in the air, but haven't used FCR for many years now, and probably would not be thinking about it too significantly.
Dr. Chaudhry?
Yes, I would completely agree. I haven't used FCR for a long time either, but I think that small slice of patients that David mentioned, the 35-year-old extremely fit, I think the issues for and against FCR sort of are putting the balance against FCR in so many ways, except maybe for one, and that's if you can actually get by with FCR and maybe, when you're sort of a very limited time for a young patient who's looking at another 65 years of life, if you can buy that long disease-free interval in that very small slice of patient, one could make the argument that maybe FCR is still an option. Though I agree with David completely. We are kind of moving away from chemotherapy mostly because of the toxicity. These novel agents are, so less toxic that it's very hard to justify FCR anymore. So in my mind, I haven't used it for many years, and I don't anticipate I will. But there is that argument to be made.
Sure. Dr. Nabhan?
Well, I may be less antagonistic to FCR than my co-panelist in the subset of patients that have the mutated IGHV. I think Paul did a great job in summarizing the trials, the ECOG Alliance, and a lot of other studies. To my knowledge, I guess, and maybe I missed it, I'm not aware that in the subset of patients that have mutated IGHV, there's clear superiority of the novel agents compared to chemoimmunotherapy. I think but not, about only 10 to 15% of patients might have the mutated immunoglobulin variable heavy chain gene. In these patients that have that, with the lack of other like 17p or TP53 deletion, I think I'm comfortable giving FCR for 6 months, and it's just a short duration and stopping. I'll say, though, that because the studies with novel agents are moving away from treatment forever and having a short fixed duration, then it becomes a little bit more challenging to make that decision, because I'll admit even if you're 55 years old, to be on that agent for 30 years, given the life expectancy, that's a long time. There's financial toxicity. There's atrial fibrillation. There are so many other things that could happen. So, putting someone on that therapy forever is really difficult in my view. But because there are treatments that are looking at fixed duration, and some trials that Paul and you comment on ongoing for minimal residual disease, I think that might shift over the next couple of years. But I would say today, in patients who have the mutated IGHV and without 17p and TP53 mutation, I'm pretty comfortable giving 6 months of FCR and stopping.
Gotcha. So since you brought up the fixed duration, so comments on fixed duration therapy, who is the patient population you would use it on, and especially if you would feel comfortable using it on somebody with TP53 mutation. What are your thoughts on that?
Yeah, there are thoughts and there's clinical evidence, and I think the clinical evidence may be lacking in really providing the proper guidance that you absolutely need to make that decision in a way that you could say, okay, I'm 100% sure I'm doing the right thing. I think that right now, in patients who are doing well clinically on an ongoing therapy, and they're not experiencing any toxicities, and they are able to afford the treatment and they afford the prescribed treatment, I would be pretty uncomfortable in stopping treatment in the high risk of disease for these patients, to be honest. I think you could add some complexity to it and say, well, what if you have the minimal residual disease and it's negative? And you will absolutely be throwing me a curveball there, because then I would say, I'm very tempted to stopping treatment when the MRD is negative, but I don't have data. I mean, if there are ongoing studies, I hope to get the results of these. But I think my threshold to stopping treatment in somebody on these treatments with high-risk disease, if they're experiencing toxicity, is lower. So I would be more comfortable. But honestly, in the absence of toxicities in somebody who's tolerating treatment well, affording treatment well, I would continue treatment right now. I don't have any evidence to support stopping.
Those are great points. Dr. Aboulafia or Dr. Chaudhry, anything else to add on that?
Yeah, the only thing I would, sorry, go ahead, David.
No, I'm sorry, Arvind, go ahead.
No, the only thing I would add is we just have to wait for the trials. And so I'd say we got to keep doing what we are doing now until the trials show that limited duration is as effective as prolonged.
Yeah, I agree, and just that that young patient who with mutated isoform and who has p53 deletions, this is a perfect person to consider for a clinical trial looking at triple therapy. So I mean, if I was ever going to think about triple therapy, this would be the context. Adding a BTKI with venetoclax and obinutuzumab, but this wouldn't be in my clinic. This would be as part of a clinical trial.
So moving forward then, in interest of time, so Paul?
Yeah, just to briefly wrap up this case then, this patient did start on ibrutinib at standard 420 milligrams daily and had a nice response and was on treatment for 6 years prior to starting to develop fatigue and progressive lymphocytosis, actually just recently, this past couple months. And so I just bring this up to point out the development of resistance both to the BTK inhibitors and more recently described in venetoclax treatment, but up to 80% of patients who progress on ibrutinib, depending on the report, will have a BTK or PLC gamma 2 mutation at the time of progression, but with broad range of the variant allele frequency to know exactly how much these are contributing. It's almost exclusively at the C4081 site, and this prevents the drug from covalently bonding, weakens that drug BTK binding by essentially 500-fold. So we'll leave it at that for the sake of time as well for now. So this is a different case, and we'll move into kind of the more relapsed refractory setting discussion. But initially, we'll see some common themes. This is a 62-year-old woman to start, with the most common presentation being incidentally found elevated white blood cell count, fairly minimal past medical history with hypertension, small adenopathy, no significant cytopenias, a high white count though at 110 with lymphocyte predominance in the immunophenotyping that we've discussed. There was no abnormalities identified on FISH, and she had mutated IGHV status. So similar to the first part, or the first case we discussed, the treatment was initially observation. Number of years later, she's now a 67-year-old woman, and at this point she has symptomatic progression with some B symptoms and still same medical history, enlarging adenopathy in more nodal regions. Her spleen's enlarged, and she does have relevant cytopenias, particularly the hemoglobin at 8.5 and borderline platelets. Marrow confirmed that the CLL was responsible for those cytopenias rather than an autoimmune phenomena in this case, and FISH now shows trisomy 12, and this is historic now, but had received 6 cycles of frontline DR. She achieved a CR with this, but ultimately relapsed 4 years later, again with significant cytopenias, this time both hemoglobin and platelets. Now we see that clonal evolution on her repeat FISH studies with deletion 17p present, and so the discussion of treatment options in the relapse refractory setting and how these will also depend on comorbidities and patient preference, similar to how we mentioned in the frontline setting.
So bringing back the panel in again, just to talk a little bit about how do you view these molecular abnormalities, or the cytogenetic abnormalities in the setting of relapse CLL, and how does that influence your treatment choice? So just to provide a brief overview of your approach to relapse CLL with these molecular abnormalities. Let me bring in Dr. Nabhan first.
Yeah, and I think it's actually a very nice case that Paul presented, because it does highlight the importance of checking molecular abnormalities at the time of a relapse or changing therapy, because you just never know. And I think this woman did not have 17p initially, right? She had no abnormalities. She just had the IGHV mutation, and I would have done BR as well in the absence of genomic aberrations. Yes, I mean, I think it's critical to check that, because if she did not have any molecular abnormality, let's do the opposite. Let's say she did not have any molecular abnormality, and she had 4-year response to BR with a complete response, and she has the IGHV mutation, which, as you know, does not change with time. You could make an argument, maybe I'll do another 4 months of BR, and she's done very well on that, I'll stop, because she has no abnormality whatsoever. But the presence of molecular abnormalities, allow you to decide on the treatment with novel agents, such as the BTKI inhibitors, as well as the BCL2 inhibitors. I think what we don't know today is, are there any specific phenotype or any specific molecular abnormality that I should use acalabrutinib versus ibrutinib, or venetoclax versus ibrutinib? Today, I think it's frankly what you're comfortable with and what the patient can tolerate and afford. But I do honestly believe that we're going to find out more over the next several years, where we can have more precise decision. So the molecular abnormalities do drive my selection of therapy in the relapse setting.
Dr. Aboulafia.
Gosh, that was perfect. I have very little to add. The only side point I'd mention is that both cases, 2 and 3, had bone marrow biopsies done, and in the context of this patient in particular, I don't think I would have even felt a need to do a bone marrow, because it would seemed obvious that the cytopenias were related to progressive disease. But in terms of molecular markers, I totally agree.
Dr. Chaudhry?
Nothing to add. Totally agree.
Okay. So let's move on to a review of literature on treatment of relapsed CLL. So Paul?
So we'll start, this is the RESONATE trial, ibrutinib versus the anti-CD20 monoclonal antibody ofatumumab, and dramatic separation in those curves for progression-free survival. But really looking at the next slide, where we focus on just the ibrutinib-treated arm of this trial, to highlight the outcomes in patients with TP53 mutation, or aberration rather, on the left and right, respectively. And so this ibrutinib is able to overcome some of the negative prognostic impact of this high-risk feature, but clearly they still do a little bit worse than patients with neither. In this slide, we see the second generation BTKI, which is acalabrutinib, which was compared against investigator's choice, which was either idelalisib, the PI3 kinase inhibitor, plus rituximab, or BR. And those top 2 lines in blue and red are the acalabrutinib monotherapy arms, so no anti-CD20 and with no del-17p in red and the presence in blue, but both look favorable and see the ability for this class of agents to overcome these high-risk features. And then moving to the CCL2 antagonist with venetoclax. This is a MURANO trial. This was, again, kind of an arbitrary 2-year cutoff with venetoclax and 6 months of rituximab compared to 6 months of BR. And so you see the improvement, I guess, is the point of the slide. You see that venetoclax and rituximab was very effective therapy. And then particularly in those high-risk groups on this plot, the DEL17P and TP53 mutation, we've already thoroughly covered the IGHV mutation status, which is right below the highlighted red box, but all groups favoring the venetoclax-based regimen. And then we've shown the importance of MRD negativity prognostically in chemoimmunotherapy, particularly with FCR, and have alluded to it some with venetoclax-based treatment. This is being shown in the CLL14, and it was really first shown in the MURANO trial here in the relapsed refractory setting, that this remains a very strong biomarker prognostically, and really some of these studies showing better than the conventional response criteria of whether or not you achieved a CR or a PR. If you had MRD undetectable status, that was actually ended up being most important. Now, these are really just prognostic at this point. The ongoing trials will be something that tells us whether or not you can use this to change treatment. If you get MRD status at end of treatment now, it's really being used to give you prognostic information, whereas the trials currently ongoing are using MRD to decide whether or not, to help guide treatment duration or exactly where you go from that point as a branch point that is clinically actionable.
Hey, Paul, a quick question. Is MRD defined by flow in the bone marrow or flow on peripheral blood?
Yeah, that's a great point. So MRD, currently, I think the kind of international standard is first off is flow, which is like 10 to the negative fourth. Maybe in the future this will be NGS defined, which gives you even greater sensitivity. And they've been looking at blood and marrow, and for the venetoclax-based treatment, certainly that there's pretty good concordance between blood and marrow to make the case to doing blood rather than marrow in clinical practice. So there's fairly good concordance between the two. And if any of the other panelists have other thoughts on that too, yeah.
No, I agree. And I think, Paul, one of the most important slides probably that you presented is what I always say is, I think everybody knows right now that the presence of MRD versus the absence of MRD definitely carries prognostic value, right? I mean, just common sense. If I have MRD, residual MRD, then I'm more likely to progress or relapse than if somebody else does not have it. But we don't know, does this mean I initiate therapy early versus late at the time of clinical relapse? We don't know if I'm MRD negative, I can stop therapy early versus the time of clinical progression. These are the two questions that remain to be answered. And at all scientific meetings, most of the abstracts that I see are always MRD positive, worse prognosis. And I feel like, okay, I know that already. Can you just tell me more? But that's a very important slide that Paul presented because, and you highlighted that, Paul. You mentioned that, this is prognostic, it doesn't tell me, and I'm glad you mentioned that.
Okay, so getting back to the case, this patient, after complete response, so CLL relapsed 4 years after completion of treatment. Hemoglobin is now, I see, sorry, I got mixed up because I went through the literature. So patient this is still where we're at to begin with. So we're just kind of going back to what those treatment options were, reviewing kind of where we were at with things and what the discussion for treatment in the relapse setting is. And here again is kind of that similar backdrop, not a strict algorithm to go by, but rather potential starting point for discussion.
So I would like to bring the panel back in again, and we talked a little bit about molecular abnormalities. The other factors that go into that is prior treatment, obviously, and the toxicities. So again, based on the discussion we have had so far, and looking at this algorithm, comments, thoughts on selection of therapies, and how you have any other comments on this. And let me bring in Dr. Chaudhry first.
Yeah, so I think for a patient who has not been on a BTK inhibitor, that's the first agent I would grab. And I think one of the important things to sort of choose therapy is not only what you've had before, but also you have to think about what you're going to use in the future. So I also don't want to sort of use everything up front. But again, if I were to use combination therapy or triple therapy, I'd want to have data to show that there was actually a significant advantage. So for a patient who's not seen BTK inhibitor, I'd definitely go for a BTK inhibitor. Now, the choice of a BTK inhibitor is obviously, there could be a good discussion about that based upon, what's the different toxicities of BTK inhibitors and what is appropriate for that particular patient. I don't think we'll ever have a head-to-head comparison between BTK inhibitors, but we do have the data of the newer generation BTK inhibitors in people who have had ibrutinib before and have not tolerated well, so it's based upon toxicity. So I think those are the things that would sort of guide my decision for the future.
Dr. Aboulafia, Dr. Nabhan, any other thoughts?
Yeah, so, to me, it kind of reminds me of the early days of HIV. We have so many different drugs, and when I go in the room, I don't necessarily know which heart regimen I'm going to choose first. It ends up being kind of a shift and change based on the patient's preferences and concerns for side effects. So patients with liver dysfunction or hepatitis are not going to be able to get ibrutinib easily because of the way it's metabolized. People who have bleeding diatheses or even on aspirin can be a challenge when giving ibrutinib. I don't have a lot of experience yet with acalabrutinib in CLL, but I've used it extensively in Waldenstrom's, and there is a study comparing ibrutinib and acal in that context, and it looks like at least acalabrutinib is associated with a little bit less bleeding issues, and so that may be one plus for it as time goes on. It does cause headache, and I've had a number of patients have a difficult time with that headache. It typically lasts for a month or so and then seems to recede. Patients with poorly controlled high blood pressure may be difficult on ibrutinib, at least for the first couple months. Skin rash can, stop the process on anybody and then have to re-challenge again. And so those are things that kind of play into the ibrutinib, acalabrutinib choices. And then, of course, anyone who's already on anticoagulants, it makes for an easy choice to recommend venetoclax as a first-line choice for them. I agree with Arvind that, that what you've used and what you're most comfortable with becomes really important here, because side effects can be tricky, and not knowing to look for certain opportunistic infections versus one drug and another all kind of play a role in this kind of shifting dynamic of, venetoclax versus a BTKI.
Perfect. That was a very good summary, Dr. Aboulafia. Thank you. So I think with that, we come to the end of our presentation, and we talked about that CLL is a heterogeneous disease. We talked about when to treat. We talked about frontline, and then role of molecular abnormalities, including IGHV, del17p, TP53, and then we talked about how these abnormalities impact treatment in the frontline and in the relapse setting. With that, we'll take some questions, and let me see how I can go to the chat.
Some of the reminders: we have our next next molecular tumor board meeting on October 4th, and it is on colorectal cancer. It will feature outstanding faculties. We have Dr. Shakti Chakravarti, he's right here, and we will have Dr. Rona Yagar from Memorial Sloan Kettering. Of course, Sidhu there, and most likely Dr. Axel Grothi will join us. Shakti, can you just talk in a couple of, just for a minute or so, what you want to focus on?
Hi, good morning, everyone. Thank you for including me in this discussion. First of all, This molecular tumor board, I have to say, was very well conducted. So I would congratulate the organizers and the panelists. Now, for the colorectal tumor board, although the targeted therapy has not evolved as well as in CLL, but this is an expanding front. So we would like to choose a couple of cases with important clinical correlations and clinical implications. I have 1 or 2 patients I can contribute. So again, thank you for including me, and I look forward to participating in the tumor board next month.
Wonderful, thank you. Also, September 26th, we have our annual ASCO highlights, and it is official ASCO highlights. So essentially, it is CME accredited, and we have some outstanding faculties from all over the country. So it is pretty well attended. Normally, we do that in Seattle or Coeur d'Alene, but this year, because of COVID-19, it's going to be virtual. Keep in mind that those who attend, there will be no food there, but you may get Uber Eats the gift card. So you can order food for yourself during that meeting. Perfect. Sid, back to you.
So anybody has any questions, comments, feel free to type in the chat. We'll keep it open for another 30 seconds or so if anybody has anything. If not, I mean, I would like to thank my panelists, Dr. Aboulafia, Dr. Chaudhry, and Dr. Nabhan. Thank you so much for being here. Paul, thank you for doing an excellent job of summarizing the literature and presenting these cases. And then Dr. Shah, thank you for this opportunity to be here for everybody and doing this educational talk.
Thank you.
Thank you for the outstanding job, Sid, and outstanding job by panelists. We have a question, looks like. In the meantime, if any of you would have interest in global oncology and global health, please contact us. We have some major projects internationally. And any way you want to get involved, you want to volunteer, you want to do research, you want to be involved in educational efforts, there are tons of opportunities. Sid, back to you.
So it does not seem like we have any other questions. So if nobody has any other, hey, Sakti, I have a quick question.
Sure.
So I see that the targeted therapies are very effective in CLL. So what's the role of allogeneic transplants nowadays?
That's a very good question. I think we briefly mentioned somewhere that cellular therapy referred to cellular therapy in the last slide. So I'll bring in Dr. Aboulafia, Dr. Chaudhry. Would you want to, anybody from the panel, would you want to answer this question?
Yeah, I guess I'd say it's a moving target, but you know, for those desperate patients who kind of fly through the first rounds of treatment and are young, allogeneic transplants are still thought about, and I think really CAR T cells are really where things are moving, and I think that ASCO was full of a lot of updates on patients with CLL who were getting treated with CAR T cells and CAR T cell pre-products that are already on the shelf. And so, again, it brings up a whole issue of, you know, for those patients who, you know, the rare patients who do relapse and relapse fairly quickly and are young enough to consider. But I think that's a moving target for sure.
And I would actually agree with David. I think there is also the discussion about, you know, in some of these patients that have received so much therapy before and headed towards a transplant, they're actually really also transforming into a more aggressive kind of a lymphoma. And so it's important for us to make sure that the patient has transformed or not. And so in that situation, a PET scan or a biopsy of a lymph node that's hot or rapidly progressing is very, very important, so as to really tease out what are we really transplanting. Are we really transplanting the relapsed refractory CLL, or are we really going for a transformed lymphoma?
Yeah, great points.
And there was a couple papers published, actually both in Blood Advances within the past couple of weeks, that showed promising outcomes. This was retrospective data, but promising outcomes with allogeneic transplant following use of novel agents, which was, somewhat of an unknown on as transplant, as you said, keeps moving back as a moving target, and with more effective salvage options, it occurs later. But 2 papers showed very nice outcomes with transplant, even in patients who had novel therapies prior to.
Great point. All right. With that, we'll conclude today's session. Again, thank you, everybody. It was wonderful to have you all here today. Thanks.
Thank you very much.
Thank you.
Thank you all. Have a good day.
Have a good day.
Thank you.
Outstanding job, Sid.
Thank you, Dr. Shah. I think it went very well. There's a lot of discussions, and really, it was very exciting. Yeah.
Yeah. Anything you would like changed in future meetings?
I think just from a time perspective, I think we went a little bit over, but I think maybe trying to put in 2 cases rather than 3 might be something that we have to consider.
Yeah, I think 2 cases would be good in future.
Yeah.
So next meeting will be, we will have Shakti from Wisconsin, we will have Dr. Yagar from Sloan Kettering, New York.
Yeah.
We would invite Mark Lewis from Intermountain in Utah, and a couple of doctors from Seattle. So we'll make it a very, very high quality meeting like this.
That would be great. Perfect. Thank you, Dr. Shah.
Thanks a lot.
Take care.
Bye-bye.
Bye. How do I log out of this?